Hi, I'm Stefan Kertes, and welcome to On Becoming a Healer. Doctors, nurses, and others working in hospitals are likely at times to walk in to see a patient with shackles in place and often with a guard nearby. This could be a patient brought over from the jail or the prison. It could be a patient who's just had surgery, or a pregnant woman, or someone even on a ventilator in an ICU. And in that moment, we're confronted with a situation. We're often surprised by something that seems to have been put in place by a protocol we didn't write. That shackle and that guard have something to do with the healing relationship we are about to try to form. And our guest today, Dr. Larry Haber, has written about this exact situation, and I will introduce him in just a moment. But for a moment, I'd like to turn to my co-host, Saul Weiner. Hi, Saul.
Hey, Stefan.
So how did we come to select this topic?
Well, I've certainly cared for patients who are handcuffed over the years when I've done inpatient medicine, and occasionally also in the outpatient setting. I work at a public hospital, and we're a referral site for the local jail and prison. And I've sometimes been disturbed by the way in which everyone around the patient seems to respond when a patient is identified as a prisoner. It's been hard for me to pin it down. I've had situations where people go and look up the crime that the person committed, and that's affected the dynamics of patient care. And so this has just been kind of swirling around in my head as something that we need to be thinking about as we focus on the theme of this podcast, which is the concept of becoming a healer, being somebody who's truly there for patients, and exploring this from the vantage point of someone who knows a lot. And our guest today knows a lot. There are two papers that we're going to be focusing on today, along with his expertise more broadly. One of them is a moving piece that he co-authored called On a Ventilator in Shackles. And he talks about, he and his co-author talk about a patient who was in the intensive care unit, paralyzed, sedated, on pressors, hypoxemic, and in shackles. And this image is somewhat haunting. And I just want to read the last sentence of this essay, which says, "There is no medical or legal justification for a patient who is sedated, paralyzed, and unable to breathe to still lie in bondage." And I'll also mention that this piece came out not long after the death of George Floyd, and this patient happened to be Black. And so I think there's just a layering of issues that we need to explore, and that's what I'm hoping that we can do today.
Thanks so much, Saul. So let me just say a word for a moment. Our guest today, Dr. Lawrence Haber, we're going to be calling him Larry, is a faculty member at the University of Colorado Anschutz School of Medicine. He trained at UCSF. He has done fellowship in hospital medicine. Clinically, Larry's focus is on those experiencing incarceration, on other disadvantaged populations, and people with substance use disorders. And educationally, he helps run a program focused on the identity and growth and development of medical students called the Compass Program. Hello, Larry.
Hi, nice to be here. Thanks for having me.
Yeah, we're thankful you came on. So just as a start, how did you get interested in this issue of dealing with patients of ours who are shackled or prisoners?
Yeah, wonderful question. I think, as you mentioned, I did medical residency at UCSF. And in that context, rotated through our public safety net hospital, San Francisco General, our main campus, our VA Medical Center, and actually would frequently come in contact with the folks who were being referred from our county jail system, mostly for care at San Francisco General. And that was my first kind of introduction to caring for patients who are incarcerated. At that time, we had a dedicated forensic unit, actually, on, I can't remember, 7th floor at San Francisco General in the old hospital. And I remember during residency going up to this unit, honestly being a bit scared going into the unit. It was behind a number of locked doors, guards, at every post. And the ways in which we interacted with the patients seemed both quite usual in terms of like the items we would be asking, the paracenteses we would be performing on them, but also quite unusual in terms of the manner in which we were doing it. After, as you mentioned, I worked for the Indian Health Services for a bit after residency, came back to the fellowship, and then actually was on faculty at UCSF working primarily at my clinical site was San Francisco General. And so I was there for about 10 years before moving to the University of Colorado, working for Denver Health Medical Center now. And so I think as a young attending at San Francisco General, I've always had an interest in safety net work and vulnerable patient populations. I think I went into it thinking I want to always be providing the best standard of care I can provide. And I think that that's generally a theme that runs through my work, working in the safety net. And I think people can go both ways. People think, gosh, these patients don't have anywhere else to go, so you could almost get off easy not providing that standard. I kind of looked at it the other way in some ways, where they have nowhere else to go, so I really have to step up to provide that standard and make sure that I'm the person meeting it, because there's nobody else that's going to. And then I think it just, the particular interest in caring for incarcerated patients in that context grew out of just my own uncertainty in terms of what I was doing in the hospital, and my own uncertainty in terms of how I was actually providing care for this group. And so started to just notice things and ask questions. And so I think some ones that commonly come up are shackles. That's the most glaring, I will say. I think that's the most visible thing you see when you're caring for folks who are incarcerated. But, questions around discharge planning. I couldn't tell them when they were going back to jail, for example, even if they were being discharged that afternoon. There were questions around patient privacy. There'd be a correctional officer just in the room as I'm taking a social history, asking them about drug use. I remember actually really early on in my attending career there, we had somebody who was on a hunger strike as well. And there were issues around surrogacy that also arose, and who had the ability to make decisions. Was it the patient? Was it the correctional center? And so I remember just navigating all this uncertainty and actually looking for resources to try to clarify what exactly I was supposed to be doing. And, this is not to say there are not really wonderful resources out there for correctional care. A lot of them, though, take place in the outpatient setting, really. And there was actually really little written on how best to care for this population in the hospital. And so I just started asking those questions and exploring what was out there, and realized it was kind of a dearth of information.
And I can say from the times that I've walked into a hospital room and seen a shackle, it's just sort of been like an upsetting but unavoidable piece of furniture in my mind, and I haven't been able to think about it coherently. But I guess as a start point, can you tell us, maybe at the most basic level, why is a prisoner shackled when they're getting health care in an inpatient setting?
It's a great question. I wish there was a simple, straightforward answer. I think we tend to look at things in the inpatient setting from a medical perspective, or just, we're clinicians, we look at things from that perspective. I think it becomes really difficult to justify that, to be honest, from a medical perspective. I think when we look at similar practices that we have here, and, we'll probably talk about them a little bit later, but, in terms of use of restraints, and we always look for the least restrictive form of restraint that we could use on somebody. And this comes with both physical and non-physical restraints. To try to, answer your question a little more linearly, it's really a correctional policy that's overriding the medical policy. And, if I had to frankly state it, in the hospital.
Is there a civil interest in this shackling? That is, could members of the public, not including us, perhaps say, look, I want prisoners shackled because I don't want those criminals to get out?
Yeah, I think that that's an argument for it, and I think that that lands in a pretty reasonable place, probably with a lot of people, and I respect that side of it as well. I think when you're looking at security practices in a hospital, right? Hospitals they're not built to be correctional facilities. They're built to be medical centers, hopefully places of healing in the best case, but they're built to be clinical spaces and not correctional centers. So really, security, I'd say, in most, at least community medical facilities that are not associated with a jail or prison or something like that, don't really approximate like correctional standards of security care. So that's the reality of the situation. And in that context, I guess I would say that the custody officers, whoever it may be that's in charge of the incarcerated patient, they have pretty broad discretion to use shackles for hospitalized patients. With any kind of reasonable relation to the interests of preventing escape, preventing harm to others.
Do we think that there's often a written code that says you must shackle everybody, or how often is this stuff pre-specified in advance?
Yeah, I think it's variable. I do think that a lot of medical facilities will have policy that addresses the care of incarcerated patients on the hospital grounds. Some may not actually specify, and some may not, I'd say, get that granular in some ways, although I don't know if this is exactly granular, where we're talking about shackling somebody to a bed. But it probably is specified, if not in the medical center's policies, it's specified in the policies of the correctional center from which they're coming, or whoever is in custody of the prisoner. I think they have a set of standards that they're also following that are much more, I'd say, blanket policies in terms of how to deal with folks in the hospital, as opposed to, I think, some of the more tailored measures that we're used to as clinicians when we're treating people in the hospital.
Okay, so we talked about shackles, but where's the guard? Prior to this episode, I recall guards being in the room, and my colleague Saul Wiener recalls guards being right outside the room. Are both arrangements common?
In terms of common policies nationally, I'm honestly just not sure in terms
Sure.
in terms of, I don't tend to have that data, but I would say, I'd say both are, I've seen or experienced both of them in practice. I've seen guards outside the room, guards inside the room, guards kind of holding the door open, navigating kind of an in-between space. And I think a lot of it depends on the policies of the correctional officers. The facilities also, I think, come into play here too, I'll just say. So I'd say there's multiple stakeholders here. We got the patient, hopefully number one. We have the clinical care team who's taking care of them and their comfort level and their understanding of the policy. And then we have like the medical center or the correctional center that we're practicing in and what those facilities look like. There's some dedicated forensic units that may look very much more like a correctional facility. At San Francisco General, when we moved into a new hospital, for example, we actually never opened the forensic unit. Speaking we, although it's in the past tense now. And so the folks from the jail that were referred for care were housed on the just general medical, surgical, or intensive care units. They were not in a dedicated correctional wing of the hospital. And so what you'd have is largely guards outside in the hallways, and then the incarcerated patient behind a door in the room shackled to a bed.
Larry, I'd love to hear you talk about the harms associated with shackling. But before we do that, I just want to follow up on this conversation. In your experience, if you or one of your colleagues asks a guard to unshackle a patient or to leave the room or to do both, what has been the response that you've typically gotten? I'm curious how that plays out.
Mm-hmm. I'd say it's a little variable. I'd honestly say for the most part, it's actually really positive. And this is just to say, I also don't mean to cast any kind of guards or correctional officers in a poor light. Those are folks who are also doing their job as best as they understand it and have been tasked with certain issues that we as clinicians maybe don't often think about and don't have perspective on as well. So I would say it's variable, but actually has skewed towards the positive, if anything, I think, once you start raising the issue. And I would say positive, but somewhat transient, if that makes sense. So in the room, if I want to do a physical exam and I want to examine somebody's limb, or I want to see what their gait looks like, for example, and I'm going to get them out of bed as I normally would, I'm going to see if they're ataxic, I can ask the guard certainly, hey, can we remove the shackle that's holding this person's leg to the bed? I'd like to get them up and walk them. Honestly, I think I'm hard-pressed to find a time that wasn't met positively. The shackle was undone and I could perform the exam maneuver. I would say similarly with, in terms of privacy concerns, because I think that was part of your question too, I'd say that one's a little trickier because it's a little less concrete, like what I'm asking. I think with the shackle, it's pretty concrete sometimes. Hey, undo this shackle so that I can move this limb, as opposed to, gosh, can you just move enough out of range where I can have a private conversation, but you still feel as though you're providing measure of security. And so I've asked people to step out in kind of the antechamber of the room, for example, if it's one of those kind of rooms, or at least to kind of maneuver themselves more into the hall. That one can be a little trickier to navigate, honestly.
I must say that I've had moments where I've seen a guard in shackles and felt that I should ask for the guard to step out, and other moments where I felt froze up, intimidated by the situation and felt, oh, I don't know if I can ask, and I don't know if that'll be well received. And if you're tired and you're not sure whether you can ask something, the tendency is to not ask.
Yeah, I would completely agree with you, Stefan. And I guess this is also just to say I'm no angel. I've had those encounters as well. I've gone into the room, I'm moving through rounds. I didn't see a proactive need per se to remove a shackle, for example, during the exam. Maybe I'm listening to their lungs or something of that sort. The guard is in earshot probably of the conversation, but I, maybe don't feel like I'm asking something that's particularly private, although again, that's just a judgment call on my part and not reflective of maybe what the patient's experiencing. So I would just say, yes, I think that's a super common way to go in these encounters. I think of that in multiple ways. In some ways where I'm like, well, yes, and maybe I can do better. Or yes, and at least though, maybe I'm thinking about it. Maybe the first step is just to get people thinking about it. Just to get people considering, gosh, if the person's shackled, should I be doing something about that? And maybe they walk out and the next time they come in, or they read something and the next time they come in, they maybe just ask if it can be removed. Or they had this lingering concern that the guard was right over their shoulder when they were asking somebody about their methamphetamine use. maybe they weren't getting the straight truth. And so maybe the next time they consider that. So I think just starting to talk about the issue, honestly, is like the first step. I don't expect everybody to be this hero when they walk in every clinical exam room. They're already doing hero's work out there. And then I think advocating for more like institutional level change is really kind of the second part there.
Larry, you've talked about some of the harms just in your comments. You've talked about the fact that patients may not be honest, obviously, if a guard is there. You've talked about the fact that you can't do certain physical exam maneuvers if a patient is shackled. But can you maybe elaborate a little bit more on the harms that you see associated with patients who remain shackled? You wrote eloquently about it in your papers. So it'd just be helpful if you could kind of walk us through some of those harms.
Yeah, I think of them in a couple of I batch them in a couple of larger groups. So I think of kind of shackles in terms of just proactive injury they're going to do to somebody. You have a shackle, it's this metal contraption tight around somebody's limb, okay? What kind of harm can that do from a very proactive sense? It can cause breakdown in the skin, causing pressure ulcers. And to be honest, we actually documented that and published something called a shackling ulcer. Can cause compression of nerves, causing neuropathy, can cause fractures in the small bones of the hands. And so all these things have been documented elsewhere as well. I think of it then also in terms of the passive harm it does, right? And so we're talking about, am I going to miss a physical exam maneuver? Am I not going to get up and see that ataxic gait and evaluate it because I never got that person out of bed? Am I not going to be able to position them? Like, let's say they're somebody who has a seizure disorder. I don't even know if they have a seizure disorder, but they have a seizure, and I need to position them in a certain way, or they're having pulmonary bleeding, and I need to lay them with, X side down to preserve a good lung, those kind of things. So there's just some passive harm that can come with it, where I'm not doing things or not able to do things that I should be able to do, either on a non-urgent or an emergent basis. And then I would say, finally, I think of kind of like this qualitative harm too. So in terms of exacerbating or precipitating or just revealing our own biases, either conscious or unconscious, I think we're pretty primed when we see somebody who is shackled to a bed to immediately think that somebody has made a determination that that person is dangerous. And they need that. They require that restraint. In the same way, when I see somebody in the hospital who's in restraints, maybe delirious, well, somebody must have made a rational determination that that was warranted for that patient. I should respect that, and then I should act upon it. So those are some of the kind of the bigger buckets, I would say, of harm. That kind of like active, I'm actually compressing something that's harming. Passive, I'm not doing something that I should be doing, physical exam maneuvers. And then finally, the element of bias that it introduces, I think, or precipitates in folks.
There almost seems to be potentially a fourth layer here. If I'm a patient, part of the healing relationship is a patient can develop and foster some trust that this relationship is to protect them and their well-being. If I'm in that bed with a shackle as a patient, I am probably going to be confronting the idea that I am a problematic person who deserves less at the very same time that the doctor may be acting without bias to show that they respect me. I'm getting two messages at once. Maybe they're from two different institutions, but they are happening in the same hospital room or in the same gurney at the same time to the same person. And I just wonder how readily people can simultaneously accommodate the idea that they're an individual worthy of care, support, and nurturance, and the idea that they're a person who is not deserving of those things.
I think it's well stated, and I don't disagree. I think that's a tough juxtaposition to say that we're here, we're caring for you, we want to help you. I'm also going to chain you to a bed. And that you as the patient can somehow reconcile those two truths, that person, that you're there, that you're worthy of that care. But the reality of it is that you're also still shackled to a bed. And I think it's hard, honestly, because we as clinicians are not necessarily the ones who are making that shackling decision. And this is not to say not to pass the buck or anything of that sort, but that's a tough space to navigate, I think, when you walk into the room. Which honestly, I think is why even playing some of the small ball of even just acknowledging, oh gosh, is that okay? Or would you mind, excuse me, Gary, would you mind just removing this while we do the exam? Can replace it as you see fit after that. That at least when you're in that space with somebody, you're really going to bat for them. You have hopefully their best interest at heart. You're acknowledging the circumstances that they're under as well. And that at least when they're with you, you're going to try to do something about it.
I often try to name the things that I think might alarm or concern patients. And I must admit, I'm stumbling over the words I would use to the patient in this situation to acknowledge I mean, maybe I don't need to. Maybe what you just described is the best thing, but are there words I should consider saying to the patient when I come in and they don't know me and I don't know them and we're introducing ourselves and there's this shackle between us?
It's a wonderful question. I'm not honestly sure I have the words to describe that. I think I could see it two ways. I think one, maybe letting your actions speak in terms of the things that you're going to try to do when you're in the room for them, or even just acknowledging it. Hey, I know this is tough and this is suboptimal. I'm going to speak with X, Y, or Z about whether we can have this removed. Those aren't wonderful words, obviously. I think two, the other option is pretending as though it's not happening. I think that may have its advantages, may have its disadvantages in terms of just trying to normalize the relationship that you're having with somebody too. I don't actually pretend to know exactly what's right. I tend to hope that we're erring on the side of more action items and letting our actions speak in terms of the advocacy for the patient. But I also think there's some value in just entering the room and just trying to have as absolutely normal as an encounter as you can under the circumstance. I could see it both ways.
Sometimes with patients there's a potential line of tension for any reason, I've just said, our goal as a team here is to provide you with the best possible care and to make sure you get the care you feel you need and to make sure we don't provide care that you don't feel you need. So I want you to speak up if I do something that raises a concern and just understand that we're ethically committed to you. I've said that to many patients. So I don't see any reason not to say it to somebody with a shackle on. Let me ask this. Is there any, let's say we do ask for a shackle to be removed and that request is granted. Is there any ethical or legal risk to the doctor or whoever if the patient then runs away or hurts somebody or does something? Will it come back to become an issue if the doctor made a decision that should not have been honored? And I don't know. Are we in trouble?
It's an interesting question. I will say I'm not a lawyer, but
okay, fair enough.
But my best friend and co-author on some of these papers is, and so he's a federal public defender in New Mexico, and so I often tap him for his legal expertise. And so I'll just, with an asterisk next to it, I'll say, no, I don't think we're in trouble. And I think actually legally clinicians should feel really supported. We're tasked with providing the standard of care. There is no difference in standard of care for incarcerated patients and non-incarcerated patients. I know getting to that standard of care can be potentially a lot more difficult, and we're doing the best we can often as clinicians. But I think if in terms of reaching that standard of care, if that involves removing the shackle or asking for it to be removed, that's actually what we should be doing and feel empowered to do that. And I don't think we'll be held legally liable should then the person get up, try to escape, etc.
And the shackling of women who are admitted for delivery of a baby, is that now falling by the wayside? States are getting rid of that, or is that still a common thing?
I would say for the most part, if you're going to look at any incarcerated patient population that has had a focus on shackling, it is actually pregnant people. And so the First Step Act in 2018 banned shackling of pregnant women in federal custody from the date on which the pregnancy is confirmed until their postpartum recovery. I'll just say actually, though, that the majority of women are actually incarcerated in state prisons. So this may not actually apply to the majority of folks we're actually talking about. And then it's a state-to-state issue. I believe last I looked at this, about 22 states and the District of Columbia prohibit or limit shackling on pregnant women. So it's not universally prohibited across the country, I would say, for folks that are not in federal custody.
Yeah, 22 is less than half.
Yes. And, there's actually been cases in the recent past, I want to say the last maybe 5 years or so, I think in New York, where a pregnant person was shackled against, I think, over the objections of the treating providers. And there was actually some legal recourse.
So in your paper, you look at the question of how often do prisoners escape during the process of being transported to medical care or getting medical care. And you found one study from 2011 in which there were 99 discrete incidents of an incarcerated patient escaping medical facilities or transport over the course of a year. And you point out that this is a tiny number, considering the total number of prisoners who are getting medical care outside their facility, although I actually don't know what the denominator is, but I'm assuming it's a pretty large number. Obviously, there are going to be some listening to this episode who are going to say, well, that's why we have to keep people shackled, because 99 people can escape in a year, and that's 99 people too many. So I'd like to start by getting your thoughts about that, because I think some people are going to come back with that.
Yes, I would say one, as you're saying, the data that we have around folks escaping from medical facilities or to and from transport of medical facilities is limited. I did identify that one study. I tend to agree. I have no interest in 99 folks escaping either. I think there's a couple of questions here. I don't know all the scenarios under which these were occurring, so I'll just state that. Two, I would just say that there's probably a difference also in terms of targeted timing of shackling practices, as I'll say, versus I think what you see most often in community medical centers who are caring for incarcerated individuals, which is really just blanket policies of indefinite shackling. And so I think in my mind, there's a difference there. And I think when we're talking about places that correctional officers have identified as potentially like higher risk scenarios, sure, I would be all for them applying targeted practices to ensure safety. I just don't know if that's what we're seeing. In fact, at least anecdotally, I don't feel like day in, day out when we're practicing caring for incarcerated individuals, that's what we're seeing at all. I don't think we're seeing those targeted security measures. So what did those look like? Were those in place during these events? So I'll just say, I'm not sure what to make of that one report.
Yeah.
Targeting is tough to do. We have a tough time refining our care to target in a mindful way in medicine. Mm-hmm. And so it's probably a lot harder in criminal justice.
Oh gosh, I absolutely. And I would just say we have a hard time, but we do it in medicine, right? We, yes. We really try hard. And it's especially parallel with restraint policies that we use in the hospital. And I keep coming back to that because I see them as similar and related, and yet they're performed very differently. It would be like if everyone I admitted to the hospital, I placed in some soft restraints, and then some of them might be delirious and combative, and then I work backwards from there. That would be a strange practice. And so in some ways, I find shackling practices similar. It's like everyone in the hospital who is incarcerated should just indefinitely and without targeted measures just have a shackle in place. Unusual.
I think what you're getting at, Larry, and tell me if I'm putting words in your mouth, but I'm starting to develop this visual model of, as you said, a collaborative relationship between the healthcare professional and the guard. And the healthcare professional's job is the welfare of the patient, who in this case happens to be a prisoner or somebody in jail. And the responsibility of the prison guard is completely different. It's to secure the patient in such a way that they uphold prison requirements, or I'm not exactly sure what the policies are that they work with, but they're trying to protect the public, of course, from this individual's escape. And I think what you're saying is that there can be a collaborative relationship. And if you approach patient care with the understanding that your job is to uphold the standard of care, and the standard of care is to minimally restrain any individual, you are going to advocate for minimal restraint of that individual as far as the prison guard is comfortable going. And that's going to vary. And ultimately, you're not responsible for whether that patient escapes. That's the prison guard's job. You're responsible for the well-being of that person. Obviously, you don't want the person to escape, but you're dealing with another expert, which is the prison guard, around that issue. That's not your area of expertise. It's not our area of expertise. So I think this is, again, I'm going to ask you if I've kind of put this right, but this is such a revelation for me because it's never occurred to me that I could do this. And I think that's really the point. But I just want to pause and see here if I'm characterizing this correctly.
No, I think you're right on. I would completely agree with what you just said.
Another part of this that I just want to make sure that we explore a little bit is this essay you wrote about the patient who is ventilated, paralyzed, hypoxic, and in shackles. And you talked about how when you commented about this distressing situation to a colleague, you got a very surprising response. You had expected them to respond the same way you did, which is like, oh my goodness, that's ridiculous. But instead, they came back with a kind of convoluted defense of the situation, saying, well, you never know. Sometimes patients are faking it. When they pretend they're disabled, they pretend they can't walk. So, it has to be this way, and so on and so forth. Now, of course, it was absurd because you had just told this colleague that the person was paralyzed and intubated. That's an objective thing. It's not something that somebody is faking. But it really kind of was a revelation for you about some of the ways in which, at least some of us, perhaps many of us, buy into the system in ways that are very concerning when you think about our oath as physicians and the extent to which we have instead become co-opted by some of the deeply held structural biases that affect this population. So can you just talk a little bit about this encounter you had and what lessons you draw from it?
Sure. I will just say too, and I don't want there to be any misconception. This was actually me working in conjunction with a doctor at the University of Pittsburgh, Dr. Bonsall, who's actually a nephrologist and palliative care doc. So this is not my tale. I was there providing kind of some expert support, some contextualization of his narrative. I think I'll just say I've had very similar experiences caring for folks, either on the medical surgical units or prior life when I used to practice more in the ICU in the intensive care unit. So that's just to say that it was in support of his narrative, and we were put together by Dr. Bree Williams, who's a mentor in this space. That said, I think it's a narrative that a lot of us share or have seen or witnessed or heard talk about. And so when I was helping him kind of flesh out some of these ideas, he shared that exchange that he had with a colleague. And I think you're exactly right. I think we're kind of sometimes co-opted into this space of agreeing with those sentiments. And I might use the word conditioned. I think, we're raised in this way sometimes. We're conditioned to believe that that's true, that the person who is incarcerated is a risk to us or to others. They must be violent. They must not tell the truth. Those kind of things. They must be faking their symptoms, right, just for secondary gain, all those things that come with it. And so I think that that's not a completely uncommon practice. I think we've all.
And by the way, I have to interrupt you because there are lots of patients who are not in shackles who may actually do those things, right?
Oh, gosh, yeah. And yes, I think it is worth stating and almost like looking at it from 180 degrees and being like, gosh, I've had those experiences with patients who have nothing to do with shackles. They're not incarcerated. I've cared for patients who have thrown things at me, who, speak in a derogatory fashion to me or to our staff, who've swung at nursing staff, who, best I can tell, feigned symptoms, those kind of things. So I think when I walk into a room, I don't really know what I'm about to experience at all. And I just, again, this is anecdotal, but I have those experiences actually much more commonly with patients who have nothing to do with the correctional system at all. And there's no signifier when I walk in the room.
I think that's an important point.
Yeah. I wonder if I could highlight something that's come out in this conversation, which is, I think, in public media, even in some journal articles, when we discuss prisoners and shackling, it's easy for us to have very strong feelings that kind of polarize. Understandably, perhaps, that the criminal justice system is really not a health promotion system. In fact, I would say it's a health impairing system in most respects. But in this particular encounter, in this way we're discussing a prisoner where there is a civil or a civic interest, I hear you adopting a posture of interest in adjusting the care for the well-being of the patient. And I don't hear you saying that the guard there or that the legal system is always wrong. It seems like you're taking a little bit more nuanced approach than we might on Twitter.
Although I just want to add a corollary to that. Some of these folks are actually in jail, not in prison. So these are not necessarily people who are guilty of anything.
They're not guilty of anything. Yes. Okay. That's very important to say. But it's the jail system is grumble in a serious way. But I hear something more nuanced in terms of how these relationships would play out in clinical care with a guard.
Mm-hmm. Yeah, I'll say two things. One, I think just Saul's point is correct about just the spectrum of folks that we may be caring for. These may be people who are being brought in custody directly from the community. There was an altercation. They were brought directly to the hospital with a fracture, and they were caring for them there. They haven't progressed at all through the criminal justice system. There are folks who are being held in jail awaiting trial. Again, have not necessarily been found guilty of anything. There are folks who maybe are serving part of a 10-year sentence and have been found guilty of something. And you can see them across the spectrum, certainly. And you're going to encounter folks that are probably coming in from all across the spectrum. You may even be encountering people that you had no idea were incarcerated in the past. And they're out and they've served their sentence, or they're out on probation, for example, and you have no signifier. Counter to that is, who cares? I don't know. It's like I almost don't necessarily care in terms of the care I'm going to provide to you. If you've been guilty of something and you're in the middle of a 10-year prison sentence, if you're being held, for X, Y, or Z reason before that, if you're being brought in from the community in custody, I guess that I just want to know how I'm going to provide the best possible care for you. So yes, we see people across that spectrum. I think the only way I want it, hopefully, to inform the care I'm providing is just understanding where they're coming from, what their needs may be, what kind of risk factors they've had based on their incarcerated status that I need to be aware of to provide them good medical care. And then I think back to your point, I think it is more nuanced than that. I think in terms of the balance between kind of the correctional system and the medical system. I don't think it's black and white always. I think that we're trying to balance that where they intersect in the medical space that we're working in. But again, I would say people are coming into our space, and in my space, I provide medical care, and I hopefully provide a healing space. So I think if you're entering that from the correctional system, people have to be aware of that kind of on the correctional side, that I may be looking at things in a very different light than they are. I don't necessarily think there's a huge black and white. And I would say that I think in some ways, sometimes I'm tempted to advocate, gosh, no one should be in shackles ever in the hospital.
Yeah.
At other times, and maybe that's an argument that really lands with some people and people can really get behind. And it's an easy message in some ways. It's very simple. And then there's other ways where I think, gosh, there's probably a more nuanced approach, and we can work backwards. For example, like this gentleman who's paralyzed, on a ventilator, on vasopressors, and still shackled. And I can say, regardless of your feelings around any part of correctional care, you must acknowledge that that doesn't even seem like a good use of resources. Like, let's just start there. let's talk quality improvement. I'm a hospitalist, and then back from there. So, like, when does that threshold get crossed? At which point you actually think this person should now be in a shackle? Is it when they're off the vent?
Larry, it's interesting because my understanding, and correct me if I'm wrong here, is that in the courtroom they take the handcuffs off because it's known that juries will be influenced by those handcuffs. In other words, there's an acknowledgement that this bias is real. And in the same way, presumably being handcuffed in the hospital also has a similar effect in sort of accentuating the bias. And so, again, first, I'd like to get your thoughts on that. But secondly, I think you just said something that just needs to be emphasized, which is that the default in an ideal world maybe is that you're not shackled in the hospital, and that what we would sort of start with is the premise. Remember, there's a guard there. Is sort of like, is there any reason this person needs to have shackles? And that the default would be, if they don't, then you take them off.
Yeah.
And there's a guard there. And then, in certain situations, the guard could be like, well, actually, this is somebody who has a track record of being dangerous, and we have evidence of that. And, we're concerned. Okay, fine. Put them on. Take them off when I examine them, but then put them back on. But the default would be no shackles, not in this place of healing.
Yeah, I completely agree. And I think that's a good summary of it. I think the least restrictive means available to secure that patient, right? And then asking folks to then proactively demonstrate any necessity that requires a patient to be shackled, or to have a guard in the room when you're with them, talking to them about a history or et cetera.
I will say that I'm feeling more courageous about asking questions. The next time this happens, I think I may approach the guard, say, hello, how are you doing? Just want to check out with you, how strong is the indication for shackles here? And I do feel like that's now a much more powerful question in my mind as a result of your coming on. Larry, I'm very thankful to you. Saul, do you have any final words? Or Larry, do you have any final words?
I would just take what Stefan said and second it. And I think we can find our own way of talking to prison guards. I don't have much experience doing that, but I might say something like, hey, Mr. Jones is pretty sick. It would be best if he didn't have any shackles on. We're going to be coming in and out a lot. He'll be more comfortable. I think we can take better care of him. Is there any reason those need to be on as long as you're here? And so just put it in some way that kind of explains to the guard what the rationale is and why this is in the interest of the mission of the hospital and the care team and the patient.
I agree. I think a question's a beautiful place to start. And I think that that's an easy entry for most people. And again, this is not to say a question around, oh gosh, what did this person do? And so I do want to just draw a distinction. Like I'm generally against those kind of questions of like, what did this patient that I'm caring for do to land them in shackles? I'm not sure I need to know that to provide them medical care.
Yeah. I'm really glad you highlighted that, because that would not be my intent when I say to the guard, is there any reason can we just take them off? In fact, maybe we should just say, can we take them off, and leave it to the guard to come back with a reason why you can't. I'm glad you pointed that out. Now I would like to propose a slightly different way of doing this and just say, is there any reason or just say, can we take these off?
Yeah, I am in total agreement. I think that idea also of humble inquiry too, if you want to be particularly courageous, you can ask about that patient, and then you can start inquiring, I've taken care of a couple patients now. Why do they all seem to have shackles on? What's that about? And you just start having that conversation. You could learn something interesting. I have to be honest, I always enjoy talking with the correctional officers. I sometimes ask them if it's a good or bad assignment. I'm kind of curious how they feel about sitting in the hospital. Deadly boring for them, or is it actually like a good gig for the day? I don't know. They're people too.
They sure are.
Well, I appreciate the humanity of that, both toward the guards and toward the prisoners or not prisoners, people who've been arrested, who are in our care. And I'm very thankful to both of you for joining in this conversation, but especially to you, Larry, for taking time to help us think about a very tricky and difficult issue.
Yeah, thanks, Larry.
Yeah, my pleasure. Thank you so much, Stefan. So really appreciate the opportunity.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.